Good morning, everyone. Today, I am going to talk very brief about the approach to the unknown poisoning in the ED. Before coming to that, I just want to give you a small introduction about the status of the emergency medicine residents all over the world. In US, we just have 3,000. In UK, we have 500. And India, we have just less than 1,000. Why I'm discussing? Because there is a very good debate. Yesterday, I have been through all the sessions from the morning to evening. In the evening, one of the journalists had raised the question. We have state-of-the-art hospitals from Delhi to Kanyakumari. But in the rural, most of the emergencies are happening. So the poisoning they happen in the rural settings. So we have to send our doctors or train our doctors on managing the poisoning in the rural settings. So I think this ACTM is giving a good platform, giving all the doctors to know how to manage. All the ER physicians, everybody know how to manage the poisoning. But I want all the CMOs, all the doctors who are working in the peripheries to know how to manage the poisoning. This is the reason I'm giving it very brief. They have very high mortality. And among the poisoning, 60% are intentional and 30% are unintentional. And among the 60% intentional also, they won't tell what they have taken. So then the challenge comes for the doctor how to treat. Now today's topic is unknown poisoning. We will just see the unknown poisoning. Among the 30% of these patients land up in the ED, how to deal with them. That's a big challenge. If you see the Indian demographic incidence, majority of them are pesticides, 25% medicines, the remaining are the household products and the environmental, and very minor is the heavy metals. I just want to start with few cases because it is not just a lecture, it's a scenario. You have got 5-6 cases with you in the peripheral settings or whatever the setting it is there. So this is the first case. So generally what we do is we get some clues. Based on the clues, we deduce some what is the cause, and then we give the antidote. Because here the person is completely unconscious and we get some clues and then we work on that. And here also the same. Many farmers, they just lie in the field or after he's spraying on the field. When he comes home, he feels sick and then he just collapses. When they bring to the hospital, you get some clues. Based on the clues, you get to get one deduction, you start treating them. The same, confused widow. You get some clues and you deduce and then you treat. Here the same, breathless mountaineer. So he was camping overnight and suddenly he became confused and fainted. And then you get some clues and you deduce carbon monoxide and then you treat. And then this is another case, Writer's last drop. And then he was vomiting all of a sudden blood and he had jaundice. And then you deduce that is a paracetamol poisoning and you treat according to the protocol. And the final one is the electrician's tumor. This person was having the muscle spasm, sweating, anxiety, and he was handling right poisoning. And then he got all the problems when there was some stimuli, and you got to the deduction of strychnine poisoning and you treat them. Very nice. So now I'm going to show you a very real case. It is the same. Just remember, you don't know what is the cause. It is unknown poisoning. Are you able to solve this case without any clues? There are 4 members of the same family who came to a dinner, and then after the meal, they had started feeling nausea and not feeling well. So they were taken to the hospital. And then what happened on the ambulance en route, one of the person got started seizure. And then after reaching the hospital, another person started getting the seizures. What do we do next? Take the history. They took the history. The ER physician was there. This is in the Tier 3 hospital. They took the history. Nothing significant. What they found was everybody was having seizures. Everybody was having the seizures. So they did what ER physician do, the initial resuscitation, airway, breathing, circulation, disability. So no matter where the case, anywhere, just you have to go the same initial resuscitation, A, B, C, D, E. So what they have done for the airway, there was frothing. So they want to do the airway protection. Immediately they went into intubation and mechanical ventilator and oxygen support. So you can see wherever there's a problem, you address the problem first. They did not address the poison first. So I want to take this as a message. Airway and breathing has taken part. And you see the circulation, it was tachycardic and hypotension. And then disability, they were not able to assess and exposure, just saw the hypothermia and then they started the killing. You see here, whatever the problem is, address the problem. Treat the patient, not the poison. So they couldn't get the initial history. So what they saw, initial signs were, they went into sample history, nausea, tachycardia, hypothermia, agitation, restlessness, and then nothing was significant. With the 3 other cases, it was the same. Everybody was having the seizures. They were admitted in the hospital. And when they took the history, they got to know that prior to that evening, she was in the garden, collected some seeds. So used that seeds and cooked one mixed pulses food and the curry. Everybody was served that one. She was not knowing they were stitched in seeds. Unintentional, accidental. Understand? But how they have managed the case? Simple. A, B, C. Sample history. That's it. Any case, unknown poisoning, don't worry about the poison. Just as the ER physician, just deal with the ABC and stabilize. But there are a few other challenges. We don't know what we are dealing with. So we have to do some tests. But ongoing thing, what you have to do is you have to resuscitate and also at the same time send some investigation for the diagnosis. And all this we have to do through the systemic evaluation through the evidence. So what is our aim? Diagnose and treat simultaneously, not just wait for the diagnosis. This is ABCDE plus don't and toxidromes. Initially, I have given 6 cases. So you draw some clues and try to fit them into the toxidromes. There are around 5 toxidromes. Based on your signs and symptoms, the clues you fit into them and you try to treat. This is generally any ER physician, anybody. They are there. Just first thing is do the resuscitation, do the ABC. In airway, as we have seen earlier, they ensure the airway is patent. Consider rapid sequence intubation or delayed sequence intubation. If it is caustic injection, you may do the awake intubation. Breathing, assess rate, pattern, oxygen saturation, and then use the adjuvants. And circulation, check pulse, BP, perfusion, and see whether there are any arrhythmias are there. If the patient is hypotensive, just start norepinephrine or vasopressin. If there is hypertension, then you start the benzodiazepine first. Never try to give beta blocker. So you have other ultrasound, other things, you monitor what is the problem underlying it is there, and then you go with the disability, and you check the GCS and pupils, and check the blood sugar. This is the 6th vital sign. We fail to do it as just a duty medical officer, but as a ER physician, we know what to do. And then exposure. We try to search for the clues. What are the clues? Any needle marks are there? Any rashes are there? Any odor? Any skin changes? So is always you have to look. And then don't forget, you have to resuscitate. Just give the dextrose, give the oxygen, give naloxone, give thiamine. Start treating. Don't directly give the dextrose. Give thiamine before that one. And then history. I told you focus your history on this format, ample format. And then what was the events leading to that? Any bystanders were there? Any police? Any EMS? And you ask what is their occupation, whether a student or they're working in a factory, exposure is there. Are they having on any psychiatric medication? Simple. And then you fit them into the toxidrome. You'll get some clues. What is toxidrome? Is just nothing but some signs with syndrome. And then you take the clues from vital signs and physical signs and you fit them into your toxidromes. And what do? You do the essential investigation. Do the ABG, look for any acidosis. Check the blood glucose. See the ECG. Any prolongation of QT-QRS is there. You see the basic. If you are having, you have the liberty, I'm doing the tox screen, do the tox screen. Calculate the acidosis, anion gap. If there is anything is there, always suspect the paracetamol. Because in India, you have to suspect always the most common things first. And decontamination, whether if they come within 1 hour, you do it. Antidotes, if the antidotes are there, definitely, and the symptoms are pointing towards that, you give your antidotes, okay? And there are something called red flag signs. I was sitting one day in the ER, I can smell the pungent smell of garlic. I told, this is organophosphate. That's it. The patient may not give the history. So always look for the red flags. Sometimes the signs will help you to do life-saving treatment. And always look for the pupils. They give the major clues to us. And seizures. Seizures are there most of the time. You look at the organic and inorganic causes, what are there? Some drugs, TCS. Simple. If anybody is asking me, what are the critical clues? How I have to manage the unknown poisoning? I'll just do the primary survey. Don't forget the treatment. Give dextrose, oxygen, and naloxone. And then just you do the ample history and do your essential investigation and try to put the dots together to form a toxidrome. And then whether you find any red flag signs, now we will get a scenario. What is that? There is a patient. 2 things, whether they're conscious or unconscious. If they're conscious, they're agitated or not. Let's see. Now they are conscious, but they're agitated. So now you go to the next thing. See the pupils. If they're pinpoint, directly go to the toxidrome, okay? Opioid toxidrome. And your pupils not pinpoint, whether they're agitated or whether delirious. And then you see systemic examination, whether they're hot or dry or wet. Based on that, you can fix into the one toxidrome. But if patient is fully conscious, just do the vital signs, see the ECG. bradycardia or tachycardia. If the bradycardia is there, you can see how much is the QRS, how much is QTC. So some of the drugs will cause those things. If they're conscious, just check the vitals and observe. Need not worry. So these are the critical clues. This is algorithm. I'll share the slides with you. This is a very comprehensive. This is the North American clinics of emergency medicine. They have given very nice flow chart how to deal with it. If you have this flow chart, very simple. Go algorithmically. Pre-hospital, they have the pre-hospital care very nice. So what do they do? When they come, they just do the initial stabilization, A, B, C, and take the history and monitor the vitals. When they do the physical examination, they see whether it is fitting into the toxidrome or not, and treat the identified toxidromes. That's it. And do some testings, what is available with you, and treat accordingly. Always is supportive care, and then you send them to the whatever the level of care you require. Sometimes this patient is not fitting into the particular toxidrome. They are just only partially they are fitting. No matter, even though they fit into partial toxidromes, you can go ahead. Because we just need clues, some clues. They may not, as in the literature, they may not show exactly everything, because most of the time unknown poison happens mixed, one drug with other drug. So you only get one of the other picture. Clues from the vital signs. So you have to always get the clues. Generally, we see only 5 vital parameters. And on that saturation, sometimes it may be falsely wrong. So that then you have to see the co-oximetry. If you suspect any carboxyhemoglobin, sometimes when I saw one patient, he was completely all right. When my nurse took the ABG, he saw the blood is completely black. He said, sir, I'm taking the sample 3rd time and always the blood is black. I'm sure it is arterial. Sir, will you do it? No, it is a clear-cut case of methemoglobinemia. That's it. Diagnosis is done. Start the treatment. 6th vital parameter, glucose, glucose, glucose. Physical examination, pulse, pupils, he is your savior. And then you see the skin, how it is, whether it's wet or dry, whether there is any rigidity and any smells. Always here is we have to act like a detective. And then do the focused physical examination. Each system, whether they are dilated or constricted, and whether they are reacting to light or not reacting to light. And then you can fit them into each category. So how is the skin? How is the neurological status? Whether they are having seizures even with a small stimuli. From history, you act like a detective. What was there? What was there? You do everything parallelly. Treat them and get the history parallelly. They will guide you through that. Sometimes what happens, the patient gets discharged, then you know what was happened actually. Diagnostic strategy. I have in my hospital, I have so many investigations. Do I do them? Immediately, I just do the glucose and co-oximetry and then do the routines. That's it. And ECG. So urine drug tests, sometimes you should be expert in interpreting the results. If it is positive, don't fix on that. If it is negative, don't fix on that. It has a pros and cons. So it is not recommended without any interpretation to do the urine drug screening. Labs, just do the core test. Electrolytes, blood gas, co-oximetry, and lactate and anemia. That's it. They will give you the clues. So if there is acidosis, you can suspect methanol, ethylene glycol, salicylate, or isoniazide. ECG clues, QRS for QT prolongation, antipsychotics. Don't trust urine test blindly, because some drugs give false positive, some drugs give negative. So it is not always practical in the emergency department to do all patients the urine drug test. Decontamination is also time sensitive. They're coming after 1 day. You are left with very little option. Antidotes. There is something called coma cocktail. You suspect the patient is not responding to anything. You can always go for the coma cocktail. And you are able to fit some pathology. You think it is opioid, directly give the antidote. Elimination. So now you have done the stabilization, have you done everything? What do you want to do next? Whatever there is in the body, you try to remove them by either doing the hemodialysis, because it's unknown. You don't know what is happening. You got your ABC, but what is your next? You have done the primary treatment. Next is you try to remove them from your body by either hemodialysis or multiple dose activated charcoal and plasmapheresis. In the end, ECMO. Special population, pediatrics, they're always in high risk, and even just small dose, they get toxicity because they have the immature metabolism. And pregnancy, sometimes they just have a small fight, directly they take the suicidal, whatever the drug is available. So geriatric population, they take multiple drugs, you don't know what is doing what. And sometimes what happens, suddenly they develop some infection and they have fever, they have reduced urine output, and they go into AKI, and the normal drug they are taking may give the complications. Brain death mimics. So these are the drugs which cause the brain death mimics, baclofen, barbiturate, and neurotoxin. So do not directly rush to declare the brain death. Summary, a stepwise approach: stabilize, ABCD, look for toxidromes, assess the vital, examine the clues, use labs and ECG wisely, and use the poison control, use the expert, and use the antidotes and decontaminants as adjuvants. They are not the primary treatment. You say, we don't have the antidote. Sometimes they refer the patient without the antidote. Don't do that. You can treat always. So they are just the adjuvants. And we couldn't do the gastric lavage. He may not be said. Don't say that kind of words to them. You hope. And next you prepare for the advanced intervention. And then you do treat hyperthermia, give ice bath. Always for these kind of patients who are agitated and giving seizures, you always give the benzodiazepine first. Shock, treat the shock. Urine drug screen, and don't rely on them. And better thing is involve the poison control, involve the toxicologist. My friend is there in Hyderabad in Software City. He suspects there is some poisoning to happen to his grandmother. He calls. There is AIG is there. My AI phone is telling something, and there is one small hospital is there, and there is poison control. Where do I go? He asked me. So you see, I'm not a physician. I'm an anesthetist and working in the emergency. I get all these kind of calls. So now you're at a dilemma where to send them. Because now people use more AI. They'll tell you, sir, I think this is this. And in the software, everybody has all the access. They want to tell which hospital is good, which hospital is bad. So I tell, just go to any hospital. They will do the primary treatment. And the ER physician, if they are in doubt, they will contact the poison control or the toxicology institute. So now the patients in India are very smart. They try to pick, but mantra is send them to any hospital. Every doctor should know what to do in the stepwise approach. If the hospital will involve the toxicologist or the expert to deal with further what to do. Every unknown toxin is a mystery until it is known. Now you have the tools, you can decode it.
Thank you. Thank you very much, Dr. Santosh. First of all, I appreciate the Society of Acute Trauma and Emergency Medicine, the team of Dr. Lokendra Gupta, for organizing such a massive and excellent conference in Lucknow, and privileged to be here, and thank you for the invite. And one more thing which I want to appreciate you, that it is right on time. I think conferences are not going right on time. Time is very precious. I came from another conference which is lagging behind in 1 hour. That is why I got late. So I apologize for my 10 minutes of delay. Time is more precious, and I think we should stick on to the time. And Dr. Santosh, you had given very good, excellent message to, I think, the students who are here. Majority of the situations, you might not be knowing what is the toxin which he or she has consumed in intensive care units. Most of the diagnostics which we send, they might be of wasting the money of the patient also. As he's rightly pointed out about the urine toxicology screen. In majority of the centers, urine toxicology screen might not be there. Especially he's in a metropolitan city like Hyderabad and New Delhi, okay, Chandigarh. These places, I'm not just naming the places, in huge cities, a lot of drug intoxications are coming up. Now, I think next pandemic which is going to happen is about depression, suicide, these things, because of the increasing number of jets and complexity of life which we are having. So, in my experience also, we encountered so many patients in which we send urine toxicology screen. Always it comes like benzodiazepine, fentanyl, whatever we are giving in intensive care unit, will come in the urine. But still, it is one of the most important diagnostic clue. And he gave another important message that antidotes might not be available in your center. But once you support the airway, breathing, circulation, disability and exposure of the patient, you should be able to save the patient. Suppose I say glucagon. How many centers have glucagon? Majority of our centers doesn't have glucagon. We have to run for the purchase whenever we suspect beta blocker intoxication. Majority of the centers doesn't have methylene blue. Okay, this experience, I tell you that intoxication might present in a different way. I was managing COVID pandemic of RML. One patient in the night with desaturation, the team told me around 2 that the saturation was 85%. I told him, okay, 85% saturation, COVID wave is going on. We have not seen the patient that time, intubate the patient and prone him. He might be in severe IPS. Next day morning, I came and saw then the saturation was fixed at 85%. Surprised to see the co-oximetry. Then we suspected that what is this here? Saturation PaO2 is 250. The saturation is 85. Then we saw the methemoglobin. He is not intoxicated. He received a dialysis session in some center in Varanasi, around 4 sessions of dialysis, and he was shifted here. So the chlorine water, the chloramines which are used in the RO plant caused the contamination and led to methemoglobinemia. So the message which I want to give again is, as he told clearly, history, very important. Then heart rate, respiratory rate, the basic vitals which you take up. Then the saturation gap, as I told you, in this case, anion gap, as he clearly pointed out that high anion gap, low anion gap, which is there in blood gas, and sometimes osmolar gap. There are three gaps which come into picture whenever you are suspecting an intoxicated patient. These three gaps will be able to yield you to some point of diagnosis. And any other questions from the audience? Any other? Dr. Yash is here, and I think he wants to add on something.
The emergency should like we have not this for 25 years. I told I have been using for 25 years, I will have it. So they bought it. So you have to persuade them or press them at times. At the same time, there are many false positives and false negatives with urine toxicology. So go by clinical diagnosis, but have the corroborative evidence from the. That many types of 3, 9, that's what.
And one more thing, he told, we should go to rurals. Probably rural person who is managing emergencies there,
Yes, sir.
he might be handling the local toxidromes better than us. He also should come and to teach us that जैसे खाना जैसे आपने दिखाया seeds खा रहा है वो खा रहा है. So
Yes,
those
sir.
they might be able to handle better than us.
Yes.
Antidote they might be doing.
And the patient, most of the time, paisa nahi hai. Treatment karo. So that is the biggest problem challenge in treating the patient.
Yeah, please.
Airport authorities, they also have various types of screens. I'll give you an example. I was traveling somewhere outside long back. I was carrying this thepla with chutney. They stopped me that this has heroin. I was so scared that they told me this is within permissible limit. I will allow you to go. But I discarded. Indian airports allowed me. You are going abroad, it's a big problem.
So it is our responsibility, as Javeri pointed out rightly, that once you receive that suspected toxidrome, where are these patients are getting these drugs from? Everywhere cocaine and everything is available. We should inform the forensic department or the government to regulate the drug supply. I think any other issues you want to answer?
Sir.
Please.
Yes,
Yeah, please.
some medical officer from PSC or CSC told me sometime the government of India is running interactive website.
Yes.
There are no on-site at rural area and toxidromes are there.
Yes, sir.
There is guidance from that website. I don't remember that. Can you tell that?
Sir, actually it is government of India is running for NCDC, non-communicable disease. They run the how to treat the snake bite, how to treat the poisoning. They have the webinars. They're for free. In Delhi, they have the Institute of the Drug Control. So they do all the lectures and webinars. But in India, the thing is bad news and rumors spread very fast. Good news that doesn't spread. So I think we have to use these common platforms. And I will give the link also to sir so that we can share those kind of links. So whatever good is there in India, it doesn't spread. So we have to spread those, as sir said rightly, government of India is doing, and that most helpful will be for the rural doctors. And we use the technology to train them so that everybody knows in the rural, because it's a huge burden. We have very less emergency physicians and we have so many tertiary centers, but everything is happening in the rural areas. And yesterday I have listened something called collaboration. So one of the sirs said, I'm non-medical, I have no suggestion, but he said, even you have to collaborate with your competitor. You see, the doctors, they are all treating it one person, is a patient. So we should always collaborate with the patient, what they are calling, and we have to have one common platform where all the doctors come together and they discuss what is the problem. And I think this Actum has given that opportunity to where all the doctors are coming. I showed in the first slide, there are very 3,500 emergency physicians. There is a lot of gap is there,
Yeah, please.
The number is who is working 24/7.
Yes, sir.
I'm using that number since last 10 to 12 years. And that number is that quick. You just have to tell the symptoms, sign and symptoms, and then they have got whole list of symptoms listed there, and then they will give you the diagnosis, they'll give you the stepwise management of the poisoning or toxidromes. So that number is there, but no one is using that. That number is such a beautiful thing. 24/7 works, and you're just wondering, pick up the call, and then they give you the provisional diagnosis, stepwise management, and they'll help you throughout the till time patient shifted to ICU or ward. But that number should be spread everywhere. That can be used by even a PSC doctor, a CSC doctor, or district health. But no one knows that. Yes, definitely.
I
So,
agree.
as I said, when in doubt, call poison control. In India, sir rightly said the AIMS number. Whenever you call, they'll definitely answer you, and your symptoms will fit into that, and they'll always guide you for the treatment.
Yeah.
And involve the toxicology people and the physician who are there. And then finally coming to that collaboration, if you do so many collaborations and spread the good news, what we are doing, public can teach, private can teach, government can teach. So teaching is never enough. We have to do ongoing, and we have to do the programs like this. And I am very happy that I have came to the Makkah of ATLS and have met so many grand legends. So the soil is enriched with so many nutrients, and there are many problem solvers here. I can see Sir has formed one organization to bridge the gap. So I congratulate Sir. These are the people like Bill Gates. They see the problem and they give the solution. They saw the problem with ATLS. They formed the ATLS center. I have seen such a wonderful center. They have around 384 instructors they have taught. So if you learn from the Makkah, like this kind of places, I went to many places, but unfortunately, nobody knows about good things happening in the Lucknow. So we have to spread the good word. People are friendly. Everybody's just not knowing about this place. So ATLS, very good centers and good institutions. Infrastructure is very well made. And we have to use the common platforms. We are the
Yeah.
teachers. We have to teach everybody.
Thank you. Thank you very much, Dr. Santosh. I think to continue the show
sir.
in right time,
Sorry.
we conclude the session.